past NOSOR conferences. Also joining me on the phone today is my colleague Melanie Panette. She's one of our senior data analysts here on our team, who's done a lot of the research work that we're going to be reviewing with you today. So just a quick highlight here of the agenda of what we're going to be covering. Just to level set, we'll just do a quick review here of kind of pre-pandemic reality for rural hospitals from across the country, kind of look at that regionally. And then obviously we're going to dive into some of our newer research as a result of COVID this year, looking at what added challenges the pandemic has laid upon rural hospitals, kind of the new normal emerging forward. And then Melanie's just recently wrapped up some health disparity gaps within rural and how that is actually increasing and things to be wary of moving forward. And then we'll take a look as well at some high-level data here for the Hospital Strength Index, which many of you I'm sure are very familiar with, to take a look at kind of the latest release of that data for the hospitals. So again, just to kind of set a level set of where we were kind of pre-pandemic, which was pretty terrible to begin with. 46% of our rural hospitals were really operating with a negative operating margin. Everyone's obviously aware of the rural hospital closures and hospital transitions. Since 2010, we have had 138 rural hospitals across the country who have either closed their doors or transitioned to some other lower level of service than acute care hospitals. Based on those closures, our team here over the last couple of years did a vulnerability study, really looking at the factors that influence the closure of those rural hospitals. We took a snapshot kind of 3 years prior to closure to see what kind of predictive modeling we could do around that, and identified 453 hospitals around the country that were indeed vulnerable to closure based on that criteria. So again, this is a breakdown, it's kind of a heat map of where that vulnerability exists. So again, 453 rural hospitals nationally. To read this chart, it basically the darker the color in each of the state blocks indicates a higher percentage of the rural hospitals within that state are on that vulnerability list or vulnerable to closure. We've also highlighted here on the map here with the blue bars around some of the around some of the state boxes. These represent those Medicaid expansion states. So again, obviously we can see some, real issues here in the deep south to the East Coast here with some great vulnerability. And keep this in mind as we look through the data today, as we move forward, looking at the COVID vulnerability and Melanie's latest data. There's some real concerns here moving forward for our rural hospitals in the kind of south to southeast of the United States. So again, just kind of a snapshot here for each of the regions within NOSOR, specifically calling out Region C. We've got 750 rural hospitals, of which 25 have closed or transitioned to another level of care. We've identified out of Region C, out of that 453, 123 vulnerable hospitals. The median operating margin for the rural hospitals across Region C is only 1.7%. Still much better than many of your peers, as you can see as you look across the chart here. And 39% of your rural hospitals within Region C have that negative operating margin. So again, as just kind of a level set there, but as we move forward talking about the impacts of COVID-19 and the rural health safety net, as the pandemic was really starting to ramp up here last year, we took a hard look at some of the real vulnerabilities of rural hospitals, and one of that being outpatient services. As you all remember, many of us had to suspend outpatient services for a time there. Some it was just a matter of a month, some it was 3 months or more. And as a rural group, we really rely on those outpatient services as part of our total revenue, significantly more than our urban counterparts. So nationally for rural hospitals, 77% of our total revenue is based on that outpatient revenue that we are getting. And again, this heat map is very similar to what we saw before. It's just the darker the color here represents a greater reliance on those outpatient services for our revenue. So you can see many of the states here in Region C are in this darker color here, 80 to 85% instead of the national 77%. So Wisconsin, Michigan, Illinois, Indiana, Iowa, Missouri have quite a bit higher than what we're typically seeing here, reliance on those outpatient services for their revenue. You know, and as those shut down, you know, it became more apparent that, you know, we were very vulnerable in our current situation. Adding to that was the availability to maintain, you know, business as usual with that lack of revenue coming in. Nationally for critical access, national for rural hospitals, we only had 33 days cash on hand at the median. You know, so again, where we were closed down for that period of time, not allowing outpatient services to come in, really that backlog really left us in a vulnerability because we only had about a month's worth of cash to continue to pay our bills and maintain and stay open. And again, this heat map, similar to what we saw before, but in this particular case, a darker color would indicate a fewer number of days cash on hand. You can see this on the far left here, this kind of dark maroon color indicates only 0 to 19 days cash on hand at the median for that particular state. So again, throughout Region C here, you can see some of this, the darker colors here, a little bit more vulnerable than what we're seeing nationally, with 20 to 39 days, Ohio, Indiana, Michigan, Missouri, Kansas. And then we get up into, you know, some lighter shades here in some of the other states within Region C with a little bit less vulnerability. One of the other things that we quickly noticed too was the lack of ICU beds and ventilator beds in our rural hospitals. Nationally, 62% of our rural hospitals do not have ICU beds. And again, this heat map is just showing again the percentage of hospitals without, rural hospitals without ICU beds. Again, the darker color here would indicate a greater percentage of the hospitals within that state without ICU beds. So you can see here throughout Region C, we've got some darker colors here between 81 and 90%, Minnesota, Iowa, Nebraska, for example. Very few of their rural hospitals had those ICU beds available. So in our rural locations, as we all knew, we had a kind of a late start to the pandemic, but when it hit, it sure did roar for us in rural healthcare. This map is just showing the percentage of hospitalizations with COVID-19. This is starting back here looking in October when things really started to change for us in rural. The rural median is noted by the darker orange line here that you can see crisscrossing the yellow line representing urban. And that went up to, you know, close to 35% of our hospitalizations were related to COVID-19 specifically in rural. Same can be said with the percentage of ICU beds that were occupied within rural and urban. Again, as we saw in those previous slides, there only 62% of our rural hospital, or 62% of our rural hospitals did not have ICU beds. So again, that availability was pretty low, but as you can see here, as we're getting close to January, when things, you know, end of December, beginning of January, when things were really getting bad for many of us, we're pretty close to that urban benchmark here of about, you know, probably 84% of our ICU beds were occupied. So very critical time for us, and, you know, really showed some vulnerabilities that we had where we were, you know, our ICU beds were full, as well as the urban setting as well. So kind of a scary time for all. So one of the things that we did do during this time was we conducted a couple of national surveys to our rural hospitals. The first one here was really looking at some of those short-term and long-term concerns that hospitals were really worried about. Short-term concerns, obviously, at the time was really, and continue to be, around staff. Really just the, you know, the pressures that our staff was under, staff burnout, staff turnover, just really hard times for our staff. So that was really the main concern, as you can see here, for our rural hospitals. Followed second by finances, quite distant second. I mean, people were really concerned about their staff at that time. When we asked them, as we were coming out of the pandemic, there, that kind of high point that we had there in the early spring, we were asking folks, long term, after kind of COVID recedes, what were their concerns moving forward? And finance moved up from the second concern to the highest concern moving forward, with staff still a major concern here in spot 2. I did want to highlight here community health. Community health in that short-term concerns was kind of 0.3, but really came with a great deal more concern for the long term. We had a lot of people that were delaying care for chronic disease, putting off, some medical needs that they had. We had a higher use of telemedicine, and we saw a lot of comments around distrust of healthcare and government at that time, and what those long-term impacts would be on community health moving forward.
Hey,
Earlier,
Troy.
yes.
2 slides back, question from the chat. I don't think you can see the chat when you're in there. I think it was about the vulnerable hospital. Penny in Wisconsin was wondering if you're familiar with the Flex Monitoring Team's financial distress model.
Yes.
Can you explain how your methodology differs? She said that your analysis shows many more vulnerable hospitals than the Flex Monitoring Team.
Yeah, I'll actually turn this over to my colleague Melanie. We had basically 2 tiers, Penny, within that analysis. The 453 was kind of the larger number between the 2 groups. We had a more vulnerable group and a, still vulnerable, but less vulnerable than the more vulnerable group.
Yeah, that's exactly what I was going to say, Troy, is that we had this most vulnerable group that was 200 or so hospitals, and then an at-risk group. So when we relaxed the threshold, were there any hospitals that were still missing the mark, that were still having those low margins and indicators of vulnerability? So I would say to you that I don't know as much about this financial distress model, but we did have those 2 tiers, and the most at-risk group was actually around 200 or so.
Yeah, and Penny, we did have a discussion with George Pink and reviewed our findings with him, and he was satisfied with our methods, and when we looked at that most vulnerable group, that's where it really lined up more closely with their numbers.
Great, thank you so much.
You're welcome. So earlier this spring, back in March and April, in conjunction with NRHA, we conducted a survey to rural hospitals as well, looking at healthcare worker vaccination compliance. And just had some highlighted slides here just to go over that quickly, and then we'll turn it over to Melanie for our new data. But at that time, 82% said that their vaccination rates were quite a bit below those of influenza vaccination rates. For those of you, that are familiar with those quality measures, we used to track that immunization rate, and that got up to like 95% compliance nationally for the rural hospitals. So significant lag compared to traditional annual influenza vaccinations. Nearly half of the respondents said that between 21 and 50% of their personnel was opting out of the vaccine. Out of that group, 44% noted it was a matter of personal choice as to why they were not getting that vaccine. And 31 cited a lack of trust in the vaccine. Attitudes are improving, but education and outreach, certainly does take time, and we have seen improvements moving forward. I read an interesting article this morning about people that were kind of embarrassed to be going to get their vaccine, and were actually putting on disguises, and they were interviewing a rural hospital, and this was kind of the scenario that they put forward, that they've seen that a few times with folks. But anyway, but certainly, you know, this is stretching resources for all of us. So I just wanted to, we had a couple of free text areas here. This one was specifically asking around education efforts within your community that were working, or things that were going well for you. And just some highlights here. Providers and staff are encouraged to converse with general population to consider the science behind the vaccine rather than the social media link to other, you know, authority sites. We utilize physician champions and multiple communication pieces and videos. Certainly that use of, you know, physicians to get that message across has been quite successful. And then we also had some pretty vocal comments around personal choice with the vaccine as well. These are just some of the highlights here that we pulled. America allows choice. Many instances of misinformation and trust gaps have not helped those who have concerns. We legally have to allow our employees to choose their own healthcare actions. There will never be a legal foundation to mandate employees taking the vaccine in healthcare. But oh, what a difference a month or two can make. As we have seen lately, there's, you know, more than 40 hospitals and healthcare systems around the country that are mandating vaccines. And we have seen the judge dismiss the Houston hospital workers lawsuit about vaccine mandates. So again, we've seen this really pick up in Region C. We've pulled out a couple of the hospital systems here within Region C that are mandating those vaccines as well. And just finally here, this was just a graphic here from July 21st from the Daily Yonder showing rural completed vaccination rates as of July 15th here. And again, the scale is going from 0 with the light yellow to that dark blue color, kind of 60s, almost 70% here. So again, within Region C, we do have some variation. You know, obviously we've got some higher levels up in Michigan, Wisconsin, Minnesota, Iowa, and then some lower rates that we see here in Missouri. Nebraska is a little bit lower. And again, you know, referring back to this vulnerability map here again that we saw earlier that I mentioned there about the hospitals with vulnerability and the darker colors here, you know, we can see that, you know, that lack of immunization compliance down within that deeper south and to the east kind of lines up with this vulnerability that we're seeing here as well. So with that, I'm going to turn this over to my colleague Melanie to lead us through our next section here about our new normal.
Perfect, thank you, Troy. So yeah, I have some new research that we're pretty excited about to share with you today, and then Troy will take you all through index performance for Region C. So as Troy so beautifully laid out, we know that rural hospitals are already facing this challenging baseline, and we really need to prepare for a new normal during and after COVID times and really evaluate the potential reverberating and long-term effects that this new climate has had. So these challenges, whether we're looking at margins or closure or access or days cash, they are really persisting. And you can imagine that these vulnerabilities layered on with the stress of COVID may exacerbate those pre-existing gaps in healthcare disparities, including access to care. In this new research, we will see specifically that the safety net is the weakest where hospitals are vulnerable to closure. And looking at those vulnerable areas having lower rates of insurance coverage, higher rates of premature death, and less access to both primary care and mental health services. So in our research, we really look to define and describe what it means to serve a rural population. Who are these populations being served by rural hospitals compared to those folks being served in an urban setting? So instead of using that more broad definition, looking at CBSAs or zip codes, we use service areas where we are isolating the best service area definition pertaining to only communities with a rural hospital or an urban hospital here. So we see a few highlighted disparities here. This is not exhaustive. This is derived from county health rankings. And the bottom line is that rural serves older, sicker, and poorer populations with less access to care. Of course, that older and poorer piece sort of highlighting the unique dependency that rural has on government payers, so Medicare and Medicaid, and consequently also the importance of making sure that those poorer populations can afford coverage, specifically with concern for those states that have not expanded Medicaid, because the biggest difference there is that the charity care being provided to those folks is not covered. Sorry, and then just before we move on, those red dots there, they represent the rural hospital service area median nationally, the yellow representing urban, so older, seeing more over 65 patients in rural settings, more diabetes in rural settings, larger veteran populations, and then you sort of see those bubbles flip. So the red bubble on the bottom now, seeing lower access to primary care and mental health care access at the 33rd percentile there, compared to more closely to the 63rd percentile in the urban setting. So the bigger picture here, rural hospitals are serving the underserved. So it's really a mission-driven environment, despite those multiple pressure points on margin and some of these hospitals actually being vulnerable to closure. So on the next slide, we're diving a little bit deeper here into a few metrics that show some geographic variation. This first slide here looking at adults uninsured, so the percentage of adults uninsured for those rural hospital service areas, and looking at the median by state. In the bottom right there, we do have that vulnerability map for reference, just so you can see how those at-risk hospitals might be at more risk or see exacerbated problems given these health disparities. So we see here, going back to that topic of Medicaid expansion, our prior research actually found that expansion status is statistically a significant predictor of whether hospitals might close. So again, in those expansion states, they are likely seeing a protective effect because those folks who would have otherwise fallen into the insurance gap without expansion are better able to pay their hospital bills. And there are some options for help in non-expansion states with that charity care, including disproportionate share provisions and Medicare bad debt reimbursements. But as we all know, there have been cuts to these programs over time, leaving those hospitals largely unable to recoup those charity care costs. So states who will feel the impacts of these cuts the most are those with the highest uninsured rates, and also happen to be, for the most part, non-expansion states. So we see Florida, Georgia, Mississippi, North Carolina, South Carolina, and Texas, all in those deep purple colors, exhibiting higher rates of uninsured adults in rural America. And Missouri here as well, showing up in that 16 to 20% range. I believe they did have a ballot initiative on Medicaid expansion, but it's currently being handled by the courts. So when we look at the same map on the next slide, but for children under age 19, looking at that uninsured measure, this map is not nearly as dramatic as the previous. We're seeing all state medians fall below that 15% uninsured rate for children in these rural hospital areas. And fortunately, as we all know, there's the beloved CHIP program that's available as a low-cost option for children whose families earn too much to qualify for Medicaid. So that certainly helps close that coverage gap for children who qualify. And when we look at a map of childhood poverty on the next slide, then we really start to understand the importance of such programs like CHIP, especially in these dark purple states where we see median child poverty rates of greater than 25% at the median for rural hospital communities. So finally on this next slide, we're looking at the non-Hispanic Black population density in rural hospital communities. And we really need to look at the state by state level on this measure. As you can see, there's pretty low penetration in most areas, except for really 5 states here. There are 5 states where the average percent of Black Americans living in rural hospital communities exceeds 15%. So Alabama, Georgia, Louisiana, Mississippi, and South Carolina. And that will be relevant in a future slide. So we also took a look at metrics where there are significant gaps between vulnerable hospital communities. So those hospitals vulnerable to closure, we actually isolated those communities, compared their median ranking across a few measures to that of their rural and urban counterparts. So already at the top here, we see these vulnerable hospital communities have less access to primary care. So at the 23rd percentile for primary care access on that measure, and the 17th percentile in terms of mental health access. And that difference on the right is compared to the overall rural cohort. And we also see in these vulnerable communities higher rates of uninsured by 20 points in the adult and 9 in children, and higher rates of premature death as well by 16 percentile points there. And when we consider disparity in the context of race, we do see some substantial gaps when comparing rural hospital communities to the urban cohort, specifically looking at premature death rates and child poverty. So we see for Georgia here, it actually was the only statistically significant difference among the states. So looking at that, a Black American premature death rate for urban is at the 46th percentile at the median, versus for rural hospital service areas, we're at the 76th percentile for that same measure, premature deaths. And then for child poverty, at the 54th percentile for urban versus the 80th percentile for child poverty. Just highlighting those, yeah. Animations. So with this knowledge of these disparities within our rural hospital communities that are already facing those operating margin challenges and financial pressures, they were facing those before the pandemic. We still have to prepare to exist in this new normal shaped by the pandemic. And we definitely anticipate that the effects of COVID will reverberate for some time and continue to amplify those challenges faced by our rural communities. So we have stacked up a few considerations for you today. So worsened community health status. Are population health dynamics in your rural markets changing? Are their needs changing? How has folks putting off care really impacted their current health status and their long-term potential outcomes? Marginal cost. So how do we evaluate opportunities to be more efficient and improve those margins? Persistence in staff burnout and shortages. So this is a big concern for rural in particular. It's, you know, not easy to fill positions in rural where staffing supply is just not as readily available. So the question here is, how will hospitals support staff while maintaining quality goods and how do we retain that hospital staff, right? So it's important to think about how to motivate your staff to maintain those quality standards, and also at the same time be able to lead with mission and vision when times get tough, especially. And then we look at reduced market share, and where are your patients going, for which services and what costs, and why. So why is this leakage happening? Are there gaps in quality? Are there better service lines offered elsewhere? Are your costs high? Are your patient experience scores low? And then finally, evolved clinical care models that have resulted due to COVID. So telehealth becoming a lot more popularized during the pandemic, and it's certainly here to stay. So Chartis has done some work with Kythera Health, actually, Kythera Labs, looking at telehealth adoption over time. And we've seen sustained adoption across service lines, across specialties and demographic groups. And COVID really has become a beaker for testing this model out, right? And it's sticking around. We went from 1% adoption to 50% adoption to around a stable 15% of total services being telehealth. So it could really become a key competitive differentiator, because not only does it provide more readily available access to care, but you can also use it to expand service lines. For instance, telestroke programs in areas without access to neuro. So that can become a life and death matter very quickly. So having that access to a distant neurologist can be a huge game changer in being able to garner that care guidance in an emergency situation. So I'm going to let Troy dig into the data in the last 20 or so minutes that we have here, and really lift the mood a little bit, I hope.
Thanks, Melanie. Yeah, so hopefully we'll end on a little bit of a higher note here after this gloom and doom. But we're going to be taking a look here at the Hospital Strength Index. Many of you are familiar with our Hospital Strength Index. This is our 11th year of conducting the index analysis. And it really serves as a comprehensive assessment of rural hospital performance. This analysis is based entirely on public data. People do not submit data to us. We are pulling information from the Medicare data sources, for claims data, for cost reporting.
Hey, Troy.
Yes.
Your audio is really faint and breaking up.
Okay. Any better?
Better.
Okay, I'll hold my mic a little bit closer to my mouth here. So again, based on publicly available data sets, in our analysis, we are looking at strictly rural hospitals. The total number is about 2,200. That includes the 1,300 plus critical access hospitals and about 900 small community hospitals not licensed as critical access. And what we are doing through this analysis is we are benchmarking each hospital's performance to that larger rural peer group across roughly 36 rural relevant metrics. And this information, again, is updated 3 times per year, and we share that information as requested. So this is a
Hey, Troy, I hate to interrupt you again. It's really faint and it's still breaking up.
Don't know what else to do.
That's weird. I can hear you. I don't know if folks have earphones they can plug in.
I'll keep trying, but I really don't know what else to do, Matt.
It's way better now, for me
okay.
at least.
Okay. So again, with the index, we are looking across 8 different pillars, basically, is what those 36 various indicators roll up into. And across the header row here are the various pillars associated with the index. So the overall index ranking score, all of the scores on this particular view are percentile rankings of how the state rural median compares to the rural medians nationally. So again, the overall index ranking, and then those 8 pillars of performance listed out left to right, looking at your inpatient market share capture, outpatient market share, quality of care, outcomes, patient perspectives, cost of care, charges, and financial capital efficiency of your organization. So the scores on this particular view, the next 2 slides, I've got each of the region C states loaded in here. But each of the scores are color-coded based on quartile performance. So top quartile performance is noted in green, second quartile is in the yellow, third quartile in the red, and the fourth quartile is in the darker gray color here. Within each pillar, I've also highlighted with boxes on the state that has the highest performance, as well as the lowest performance. So the lowest performance is noted with the red box. The green box represents the highest score for Region C. So again, I'll give folks a moment here to go through. I'll just describe these briefly, and then we'll go on to the next grouping of hospitals within Region C. But for Iowa, we can see some really strong scores here. Overall index ranking score puts them at the 75th percentile. And that overall index rank is based on an equal weighting of the 8 pillars. It is not an average of these scores, but an equal weighting. For Iowa, they ranked top in patient perspectives. At the median, their hospitals are at the 74th percentile. For Illinois, Illinois is kind of in the middle of the pack here as far as overall performance. They were the lowest performer in inpatient market share capture at the 36th percentile at the median for the hospitals within the state. Indiana as well, kind of in the middle of the pack here, with their lowest performing area in charges. The lowest of the groupings here for a low charge score would indicate a higher average charge per case as compared to your peers. Kansas is doing quite well here, 69th percentile overall. They were the highest performers for inpatient market share capture, with their hospitals coming in at the median at the 77th percentile. Their charge position is also quite low as well. They were the highest performing state with charges, indicating a lower average charge per case for their services. But however, that may be having an impact on the overall capital efficiency of their organization, kind of coming at the lower end. So kind of a balancing act there between charges and overall financial efficiency. Michigan doing quite well as well, overall at the 67th percentile here. For the quality pillar, they are in the lowest performing group for the states, coming in at the 40th percentile. However, outcomes are looking quite strong here. They are the highest of the group at the 72nd percentile. And cost efficiency as well, the highest of the group in Region C at the 74th percentile. Moving on to the next group of hospitals within Region C, we've got Minnesota here at the top. Again, Minnesota's kind of in the middle of the pack as well. For outcomes, they are the lowest performing state out of Region C at the 43rd percentile at the median. Missouri is our next line here, the second line down. For overall index performance, they are the lowest performer of the group, coming in at the 27th percentile at the median. And they also have the lowest performance for patient satisfaction, those HCAHPS scores as well, coming in at the 36th percentile at the median. One of our highest performing states here is Nebraska. I think I saw Nancy Joe on the line as well. Overall median performance for those hospitals within the state is at the 79th percentile, with the state leading in both outpatient market share at the 81st percentile and quality scores as well at the 79th percentile. Where Nebraska does struggle is in their cost position. Their cost position is quite high, the lowest of the group at the 14th percentile. Ohio is next on our list. I saw Daniel on the line as well. Again, kind of in the middle of the pack here. Ohio comes in at the lowest performer of Region C for outpatient market share. And Ohio has a really tough time there. They've got all of their critical access hospitals were giving that waiver to bypass the 35-mile rule. So they've got critical access hospitals, 10 miles apart from each other. So they're not only competing with, larger tertiary facilities, but also competing with other critical access hospitals within their service areas. And then finally, Wisconsin, again, really strong performer here. Overall index ranking scores, putting them at the 72nd percentile at the median. And as far as financial efficiency, they are leading your group here at the 66th percentile at the median for the group. So again, as you're all aware, we do annual recognitions for those top performers, the top 100 critical access hospitals, as well as those top 100 rural and community hospitals. This map here is just going to show where those top 100 critical access hospitals are located. And the size of the bubble here just goes to show the number of hospitals, top 100 hospitals within any given state. So Kansas and Nebraska are leading the pack here between 14 and 17 hospitals in each state, followed closely behind by North Dakota and Iowa with between 10 and 13. For the rural and community hospitals, a little bit more widespread than that big cluster that we saw in the Midwest. A little bit wider dispersion here, but the top states here for the rural and community hospitals, Michigan, as well as Texas, followed by Wisconsin. And with those top performers, really, as you can see from this chart here, the top performers are really outperforming their peers across all aspects of those various pillars within the index, with the top 100 median scores noted in the navy blue, and then all other critical access hospitals within that grouping, taking out the top 100, noted by the yellow bar here. So really across the board here, outperforming their peers significantly. And just some quick numbers here. Since we've been conducting our top 100 awards, we have recognized 373 different hospitals since 2011 when we started this program. We've had 3 10-time winners. We haven't had any that have been all 11 years, but we have had 3 top 10 winners, 3 9-time winners, and we've had 6 8-time winners. With Iowa, Kansas, and Nebraska having the most top 100s over that period. Iowa with 42, Kansas with 33, and Nebraska with 30. For the top 100 rural and community hospitals, we've only been doing this recognition since 2016, so about 5 years shorter than the critical access. And during that period, again, we've recognized 220 different rural and community hospitals. We have had 22 6-time winners and 16 5-time winners, with Michigan and Wisconsin with the greatest numbers, 17 and 14. And then with 12, we've had Ohio, Minnesota, Pennsylvania, and Texas coming in with 12. So on your screen here, I know this is a lot to look at, and we can certainly distribute these slides to folks to get a better view. But this is a listing of the full listing of the Region C top 100 critical access hospitals on this particular slide here. So I'll just give folks a second to take this in, find your state and find your peers. And then with the top 100 community hospitals for Region C as well. Great. So I want to give folks some time here. If we had some questions that folks had, we're happy to circle back and review anything again, or if folks had questions that we could answer. Our contact information is on the last slide as well. Again, I'm Troy Brown, up in the upper right-hand corner here, and my colleague Melanie Panett on the line with us as well. She's on the left-hand side in the middle there. So if anyone has any questions, again, Matt, I can't see the chat box through the display mode. So if there are any questions, just let me know that come through on chat.
Yeah, I've got one for you. You said that the top hospitals outperform the other hospitals significantly. And Chris was wondering, can you provide the alpha for significance, even if it's just on offline afterwards?
Yeah, yeah, for sure. Represented on this slide here. I mean, and not, I'm probably using significance incorrectly, but you can see that they are outperforming the non-top 100 median performance for each one of these areas.
Any other questions, or anyone want to come off mute to ask a question? Make a comment?
I guess, Matt, this is Joyce in Indiana. I would just have a comment. And I'm not a finance person, so I would really just need time to go back through this and digest it. But, you know, at the end of the day, especially in Indiana, it shows we're not doing so great. But yet, I find it interesting that when the hospitals have been given so much money, and I understand it has restrictions, you know, related to different aspects of COVID, they seem to be balking somewhat of acceptance because they just don't feel like they can spend that much money. But yet here from a financial standpoint, it shows that they're struggling. So I just find that interesting.
Yep, for financials, they're not doing too bad for Indiana. At the median for the hospitals, a little bit better than the national median at the 54th percentile. Where they are a little bit higher or lower performing than your peers is here under the charges. This lower score in charges indicates that the average charge per case is a bit higher than what we typically would see for rural hospitals around the country. And again, those charges are case mix and wage adjusted for each state.
Okay, I guess I would need to go back and look at it. I think I was thinking back to the slides that address vulnerability, and I thought it showed Indiana was in the higher percent in that type of category. So that's what I guess I was thinking, or struggling to understand why they wouldn't want money.
Yep, so again, not too bad when you look at your peers across the country. So this is that vulnerability slide here for Indiana. So about 10 to 15% of the hospitals within your state have been identified as vulnerable. So not too bad compared to many other states.
Anyone else have any questions? Want to come off mute and comment? Going once, going twice. All right, well, I don't see anything else in the chat, so thank you very much, Troy and Melanie, for presenting today. I really appreciate it.
Absolutely.
Sure thing, thank you.
And like I said, we'll have the